This is Cameron Glenn. Dr. Glenn, right over here. We forgot to record an intro for our podcast today, so here we are. Welcome to podcast number 6, Glenn's on Men's Health. Hope you enjoy.
But so we're talking about the possible supplementation of NMN, which is Nicotinamide Mononucleotide. So I take that every day. I have for a few years as a supplement because I feel like it helps boost energy, but it's not like caffeine energy where you're kind of like wired and high, higher adrenaline throughout the day. It's kind of we're talking about cellular energy, which is, yes, can contribute, I think, to your overall feeling of energy, but it also has to do with the energy that your cells use for DNA transcription and DNA repair mechanisms. These were kind of studies as chemicals for improving longevity and reducing errors in DNA transcription has to do with avoiding cancers and things like that. So NMN helps increase NAD+, which is an intermediate substrate in the Krebs cycle. So it can improve cellular energy. There's also nicotinamide riboside, which is it's another oral supplement, and some debate over which one's better. Some people think the riboside is more stable and better absorbed. But in animal models, NMN has worked really good. For a while, it was very expensive, very hard to get, but it's pretty cheap now. So now you see a lot of peptide clinics now talking about or advertising the NAD plus as an injected peptide, which has the same, idea behind it, so initially, NAD Plus was offered as like an infusion, with a bag of fluid that given to you in an IV over a couple of hours, and results in like flushing and all this. Yeah, and the part of that is, so have you ever taken niacin?
No.
Niacin is vitamin B3.
Oh, yes, I have then. I guess.
Well, you have
vitamin B.
You haven't taken it as a pill. Probably because when you take it individually as a pill, you get this flush, and it's very people who don't know they're going to have it. They're thinking they're having an allergic reaction. Your skin literally turns red, especially on your face, and burns for 30 minutes or 45 minutes, and you get a visible flushing. But so nicotinamide, riboside, and NMN and NAD plus are all this kind of derivatives of the B vitamin that, and there's probably some nuance to that, and somebody might correct me in the comments, but the whole idea is that it increases your cellular energy. And so this new peptide now that people are using, the NAD plus, is kind of a replacement for this infusion. Some debate also about whether a little peptide injection can really achieve the same results, but people are saying that it's helping with their energy overall. So if guys on TRT are looking for that little extra kind of boost and feeling like they need to kind of improve their energy in addition to whatever your testosterone is doing for you, adding an NMN supplement might be helpful. I've had good success with it over a few years, and I can definitely when I don't take it daily, I know I'm okay, I got to get back on my NMN.
Oh, okay.
I'm just dragging. I'm just more kind of sleepy and dozy throughout the day. Less kind of gym performance and stuff like that. So something to consider.
Oh, that's cool.
It has been in the past pretty expensive, but it's come down quite a bit. I think I can get 100 and something pills for $30 or something.
Something like that.
Your standard supplement cost.
Yeah. Right. And is that something that you would need a prescription for?
No.
Oh, okay.
No, it's just a supplement. Probably should have a prescription for it, but in our country these days, you can get a lot of stuff without a prescription if it's classified in that in that supplement category.
Right. I know we talked about the 250th celebration that UFC at the White House.
Yeah,
situation.
Strange times, man.
I was really surprised at how many people I saw there. I saw there. Shane Gillis was there. I mean, I know that he's kind of like obviously a sports guy, but like the UFC. Nate Bargatze, is that his name? Bargatze? Yeah.
Okay. Yeah.
He was there too.
Comedian.
Yeah, the comedian.
I would have gone if I were invited.
Yeah.
Where's my invitation, Donald?
It was kind of, definitely a spectacle. Somebody made a comment too. There was like a picture of one of those, those ring ladies. I guess they all were decked out in like, red, white, and blue stuff. Mm-hmm. One of them looked exactly like Firecracker from The Boys. Like, this is exactly
her. Do you think they did it on purpose?
No. Well, I don't know. Probably not.
Maybe some costume designers like a little tongue-in-cheek joke.
That'd be so funny if they like try and slip that, see how far you could go with some of those references. Someone would catch it though. Somebody, it's so popular that they would just catch it. But
yeah. Okay, so you had some stuff you wanted to talk about this week. We talked. One was sleep. Mm-hmm. So sleep is a multifactorial thing. Yeah. With testosterone, we talk about poor sleep is one of the kind of pillars of
I don't sleep great.
Yeah. Well, it's a symptom of low testosterone. And there's overlap with metabolic syndrome, obesity, obstructive sleep apnea, and other metabolic diseases that all kind of can factor in for poor sleep. But so it's often not enough to just put a guy on TRT and then just like expect his sleep is gonna improve. Mm-hmm. But insofar as testosterone replacement can help with your activity and energy level and exercise, those all have very strong connections to improved sleep. So improving your overall health with testosterone replacement gets you back to where you're doing the things that improve.
Oh, right. So I'm going to get back into the gym. I'm going to expend energy in the gym. That's going to make me more tired. And so when it's time to go to sleep.
Yeah.
Right. Yeah. I'll be more tired, more ready to.
That's the idea.
Right.
But there is specific benefits to testosterone itself for sleep as well. And then oftentimes, metabolic triad patients who are overweight and stuff will tend to lose some weight when you get their testosterone or their hormones optimized. So losing weight can improve obstructive sleep apnea. As little as 5-pound weight loss has been shown to improve sleep on sleep studies. 5-pound weight loss.
Yeah.
Which sounds like nothing, but that's a thing for sure. Personally, I lost 40 pounds with the combination of TRT and a GLP-1 medication. So,
oh wow,
yeah, my sleep is just incredible.
Were you a snorer before? Did you snore?
I've never been a snorer, but I can't sleep on my back.
Really?
I have to sleep on my side. If I sleep on my back,
sleep apnea, like you just can't get a breath.
I don't know. Like I'll
gotcha.
Wake up with. I'll sometimes like roll onto my back and then
kind
of wake myself up. But
our dad has sleep apnea.
He does, and him being on a CPAP was like a life changer for life saver.
Oh, absolutely, yeah. I just remember him always looking tired, and then him finally getting the breath that he needed. I mean, there's some other factors there.
Do you snore?
I do. Mm-hmm.
Have you ever had a sleep study?
I did, yeah. I did the one where they like just connect the one that you do yourself, where you connect all the electrodes up to yourself.
Oh, and just like at home, you're at home in your own bed.
Yeah. It came back. Yeah, you basically box it all up and you send it off to somewhere else. And it's like, nope, no sleep apnea.
Oh, that's good.
I know, I was really surprised.
How long ago was that?
It was probably 3 years ago, 2.5 years, 3 years ago.
I'm afraid to do one.
Oh, are you really?
Well, I've heard that. Yeah, my dad was telling the story. It's like if you get diagnosed, then the doctor was like threatening to like put it on his license. Like apparently it's something that has to be denoted on your insurance or your license or something like that.
Sure. I mean, certain
until you buy the expensive, machine.
it's kind of like
I remember
it's a bit of a racket, isn't it?
Yeah. I know.
They kind of get you that way, don't they?
But I was surprised to hear that I don't have it. I am a side sleeper though.
Yeah.
And I don't. Sleeping on my back, the part that obstructs my sleep is just waking myself up with my own snoring.
Okay. Yeah. Yeah. I mean, snoring in itself is not great, but snoring is not sleep apnea. Mm-hmm. I mean, they're not the same thing, right. But definitely apnea can start with snoring and stuff like that. So it's not to say they're not connected and mutually exclusive, but they very much.
Right.
I mean, everyone who eventually develops apnea or obstructive sleep apnea started as a snorer. Mm-hmm. So, yeah. I'm just worried to get a sleep study because I don't have to have sleep with a mask every night.
Or sleep. Yeah. If you're a side sleeper, I've heard that's fine, right?
Yeah, no, it's, as long as I can sleep just fine. My wife sleeps on her belly every night. I don't know how people do that.
I have no idea either.
That just seems I mean, when I was like a 10-year-old, I slept on my belly. But
yeah, I would wake up on my stomach or something like that.
But just having my face mashed into the bed like that all night.
Like my neck.
And the neck, yeah. Just
probably not good for your posture. I had a coworker too who, we had this conversation about, he's a bigger guy. Maybe he's probably 270, 280 pounds. And he's like maybe 5'9", 5'10". Mm-hmm. But yeah, that's what he said. I don't snore because I sleep on my stomach, and to me that sounds really dangerous, especially if you're overweight.
Right.
But he kind of does this one position where he's kind of like on his stomach, but he's kind of tilted on his side with his hand under,
like 3/4.
Yeah, he kind of described it as like the drunk person sleeps. Like if we throw up, it kind of goes to the side or whatever. You know what I'm saying? You know what I'm talking about? Like
the recovery position.
Exactly. That's what it's called. Right. Yeah. And I tried to sleep on my stomach. I just cannot do it. It's like a claustrophobic feeling.
You know what's interesting though is when someone is like during COVID, when patients were just circling the drain, mm-hmm. You put them prone. In fact, there's these in the hospital. We use these very expensive rotoprone beds sometimes, where you basically strap a patient in. They're like on an intubator, like they're intubated on a ventilator.
Yeah,
and the bed actually
flips like that.
Yeah, and so and the reason why is because you can ventilate more of the lungs when someone's prone.
Okay. Because is it gravity that kind of does its thing?
So it has to do with the pressure gradients of blood versus air in the lungs.
Oh, okay.
And so, but most of the mass of your lungs is towards your back. That most of the alveoli. Anyway.
No, that's interesting. I like
it doesn't. I don't think it makes a difference for the average person, but when somebody's when you're having trouble oxygenating somebody adequately, proning them makes a big difference. So I don't know.
Recovery. That's why it's a recovery position.
I guess so. Yeah, it's kind of cool.
That's interesting.
So now, I would never want to tell somebody not to get a sleep study if they think they needed it, you know, because it can be really a game changer for some guys and frankly, life-saving.
Yeah.
And all the other, and we're about to talk about this stuff, but all the other factors that sleep affects. Mm-hmm. As a general surgeon, one that I am acutely aware of is problems with digestion. Mm-hmm. A lot of digestive problems can come from chronically poor sleep. Mm-hmm. And this has to do with how your digestive system mostly does a lot of its sort of cleanup mechanism at night in a way. There's a lot of motility that goes on, reabsorption of nutrients that during the day when you're, your adrenaline is higher and you're kind of more activated systems are going, a lot of the digestive function decreases. And so sleep is very important kind of for improving. And that this may have implications. I say it may have because I don't know about a research link, but it may have implications for GI cancers, colon cancer. And I know it has effects on like GERD and indigestion in the sense of acid reflux and things like that.
I'm still thinking about snoring.
Oh yeah.
I don't know why. The trick that worked the best for me is I got one of these things that you put in your mouth that brings your lower jaw.
Oh, you actually got one of those?
I did.
You have your dentist make it for you?
Mm-mm. No, you
just a kind of a no-name.
Buy it. And I think I'm trying to remember if you actually had to. There was a part of it that you actually had to like heat up and form like a mouth guard.
Okay.
But what it did is it had basically two trays that were kind of moving against each other like a sliding door. And what you would do is you would start at a certain position with your jaw in a certain position. If you snored, then you adjust it so that the bottom comes out just a little bit, to the point where basically like I use Snore Lab to track my snoring, and you go to the point where you're not snoring anymore. Well, it wasn't that far out for me, but over the course of a week, I could feel my jaw, my bite shifting.
Oh, really?
Yeah, and the next day I would sit there at my desk, and probably at around noon my bite would get back into place. Well, as the week progressed, Tuesday it started to be like 1 o'clock, 2 o'clock, 3 o'clock. The next day it was like 3 o'clock. So it was progressively taking longer for my bite to get back to where it needed to be.
Okay.
And I'd kind of read up on that. People ending up like at the dentist's office or needing some kind of like correction. Yeah, and I'm like, I'm not going to mess with this.
Huh. I mean, my kid's orthodontist advertises like a
do they do that
some kind of custom
yeah,
I forget what it's called, but it's
maybe it would be something,
it's an appliance,
like that. Right?
I wonder if that would make a difference.
Well, yeah, possibly. I just got to the point where it was like it's going to be easier and better for me in the long run to just exercise, just lose weight. And okay. It's easier said than done.
Well, other benefits and stuff.
Right.
As
yeah,
well,
totally. But I just got to the point where I was like, before I put thousands potentially of dollars into finding this solution because I refused to, go to the gym, like just, okay, let's just circle it back. And I know that people do need like, there are skinny people who have sleep apnea. Right. Right. Yeah. So
no, it's true. There's not all sleep apnea is obstructive sleep apnea.
That's true.
So, yeah, I worked with a doctor once that was like 6 foot 3 inches tall and very thin, but had suffered with debilitating apnea. He had to take a nap.
They just stopped breathing for whatever reason at night.
Yeah.
That's scary stuff.
Sometimes just very heavy sleepers and stuff. So,
interesting.
Yeah. There is actually, there is like a craniofacial surgery. I mean, there's the surgery that removes like some of the soft tissue in the upper palate and the uvula and stuff, tonsils, adenoidectomy. They do all of that at one time to help kind of remove some of the soft tissue that causes snoring. But for some people, that's not enough. And so there is actually like a craniofacial surgery that's being done in some cases where they actually cut your upper alveolar ridge, which is right along under your bones here, basically cut the whole bottom of your face off and move it forward 1.5 centimeters or 1 centimeter
to enhance airflow. Or
well, what it does is it moves the whole. It opens up. Basically, it's like it's that space at the back of your throat, but it opens that whole thing.
Yeah,
thing up. It's more than this. It's like the whole lower face comes forward. But from a cosmetic standpoint, that's supposed to like improve your overall cosmesis and stuff.
I know if my chin wasn't so, like I think if it just came out like a half an inch, I can even just feel it. Like,
Yeah, you
just
feel it open
breathing.
up back
Right,
there.
exactly.
Yeah, but imagine not just that, but all that upper palate
Sure.
too coming forward, so
Right.
you can inhale better and stuff. So
Right. Yeah, I have a deviated septum too in my nose, so I sleep with. I'll do like the breathe right strips,
okay,
and on days when I'm more congested than others, I'll use like a nasal spray.
yeah,
Yeah, like a Mucinex or something like that. I gotta kind of be judicious about that because it's kind of addicting.
yeah, it's habit forming.
Yeah, I mean, like to go from being slightly congested to being able to breathe.
Yeah, but you get rebound congestion, especially with
Right.
Mucinex isn't going to be bad, but it's like your Afrin, which is that's a alpha agonist, which shrinks the blood vessels up there, but can cause pretty significant rebound.
So you just need it forever.
Well, yeah, and then you have to basically eventually have to just stop.
Get
using
off,
it.
right?
I think it says on the bottle on like an Afrin.
Don't use for.
I think it's more than 3 days.
Yeah, I don't use it consecutively. It seems like the later I stay up, like for some reason, like my muscles are a lot more relaxed. I don't know what it is, dude.
You need to go to bed.
Sounds
like you need to go to bed.
Life's too exciting to sleep.
Cam and I had a grandma. We were just talking about her earlier. She had some other things going on.
Quirks, let's call it.
But she never went to bed before, I think, about 3 a.m.
Oh, yeah. She was a night owl.
Just like an absolute night owl. Even when we were like over at her house staying, you'd go and sleep at grandma's house.
You're shuffling around.
You'd hear the front door lock being unlocked and relocked, 3 or 4 times in the middle of the night.
Then she'd wake up the next day and say, "Oh, somebody's been in the house, like moving stuff around."
It was like, I think it was you, Grandma.
It was you. It was you.
Yeah. So,
Oh, boy.
Anyway.
All right.
Can ED be an early warning sign of heart disease? Yeah, but probably not that early, to be honest with you. Depending on the age of the man, probably more like a middle warning sign.
Okay.
A sign of progressive heart disease. Really, a guy in his 40s, I guess 40th birthday, probably needs to go and start regular lab checks if he hasn't already. And he needs an A1C because of the link between diabetes, prediabetes, and heart disease, vascular disease in general, and which is the strongest link for heart disease. And then he needs his cholesterol panel checked regularly. So those are just lab tests. You just go do some blood once a year. That's easy. You probably don't need to start EKGs yet. And unless you have other metabolic things going on, if you are diabetic or really obese, then you kind of need probably some additional testing. And I'm not a family doctor, who deals with this every day. There's algorithms and stuff built around, when you need to start screening for these things.
Right.
But definitely, like in a man in his 40s, needs to be up on those things. His A1C and his heart and his cholesterol panel. The other thing that we check on every new TRT patient is the PSA, which is prostate-specific antigen. We also check estrogen on everybody when they come into starting out. So those are sort of the main ones.
Good. Interesting.
Yeah.
On the so we're talking about too with TRT, and I know that it affects fertility, right? And don't you recommend that guys who aren't done having kids yet, they don't start TRT until after that period because it can affect their sperm count or sperm production?
Yes. So the feedback loop that causes your body to make its own testosterone is the same feedback loop that causes your body to make sperm. So by adding exogenous testosterone, we turn that loop off. And so your sperm production goes down.
Yeah.
Pretty much in most men to almost nothing.
Right.
That's not to say it's a form of birth control. I would not rely on it that way.
Right.
But you're going to have low sperm production. For most of our patients, that's not an issue. These are men in their 40s and 50s who are usually done with their families.
Yeah.
But if you're a younger man and you are a candidate for testosterone replacement, but you still want to like father children, you may want to consider another option. One of that would be like enclomiphene or something, which can boost your testosterone levels without having the effect of reducing your fertility. In fact, can increase your sperm production.
Oh, okay.
Can have the opposite effect, and is sometimes used by fertility doctors to help improve male fertility.
Okay. Now, does that improve the quality of the sperm as well, or just improves sperm
No,
count?
quality of sperm is based, in my understanding, purely on the man's age.
Oh, okay.
Yeah. Younger men have their sperm is, you're born like with your zygotes, and so your younger man is going to have younger, better sperm typically.
Right. So there's nothing you can do necessarily to like improve the quality as you age?
No, but with sperm, it's like quality is quantity. You know what I mean?
Okay, got it.
So it's really all about the count, the sperm count for most men. It's not like for women where their age has a big effect on the quality of the eggs. And this, you're getting into some kind of nuanced fertility stuff that I don't deal with too much, but
sure.
Yeah, for men it's mainly like sperm quantity you're trying to
Gotcha.
maintain. So the other thing that happens, and this can be kind of a cosmetic issue, is when you supplement testosterone, men tend to, the testicles shrink.
Mm-hmm.
And now I'm not talking about
I've
like
heard that.
I was in the pool kind of shrinkage. This is like the actual organs themselves shrink. We may have, I think we've talked about that on the podcast before.
Yeah,
but,
we have.
in most cases about a 50% shrinkage. So usually not an issue, but some people don't like that.
Alarmed by that a little bit, right?
Yeah. Medically, it's not it's not unsafe in any way. It's just changes the appearance a little bit. Yeah.
Mm-hmm. Yeah. One of the benefits of TRT is men's ability to kind of have energy to get back in the gym. Well, when they're in the gym, to work out a little bit more, but it also affects their ability to build muscle too, doesn't it?
It does. Build and maintain lean body mass for sure. To a significant degree. One of the things that men can happen to men, or
why do they lose muscle?
it's not just men, and it's women and men. But you tend to have muscle loss as you age. In surgery, one of our markers for how someone's going to do with surgery, especially when they're elderly, is the presence of sarcopenia or loss of muscle. There's actually been studies that gauge the thickness of the gluteal muscle on a CT and then give that person like a frailty ranking, and then we can directly correlate that to how somebody tolerates surgery, like for a hip replacement or something like that, and so
because I'm disadvantaged in the gluteal department. So are you talking about something different? Is it like,
you poor thing?
I know, right?
Start.
I hope I don't have surgery because
It's not that specific, like your butt specifically
right.
helps you. It's muscle mass overall. It's lean body mass, and so a few things happen as we age. As your energy level and your metabolism slows down, your body just cannot hold as much muscular tissue. It tends to and someone who's really frail and has a lot of complicated medical issues and isn't very active, is kind of like partially bedbound, or just very sedentary is going to lose muscle mass. So there's a metabolic factor, and then there's an activity factor. And testosterone replacement in a man is going to have some effect on that and help him maintain his muscle mass longer, reduce some of that frailty. There's also good studies that link the muscle mass to survival with certain types of cancer.
Oh,
So survival rates for certain types of cancer, and that's what's assuming, chemo and surgery and stuff, whatever type of cancer. So somebody who starts with a higher muscle mass is going to have a better outcome. And that makes sense because of the, increased, protoplasm. It's kind of a catch-all word we use in surgery sometimes. If someone's generally healthy, they have good protoplasm, we know they're going to heal well, they're going to be able to tolerate a greater assault.
Oh, okay.
And that comes along, you ask, one of the questions that's often asked is like, how much protein should a person eat? And there's a lot of studies on this. There's studies for bodybuilders, and there's studies for competitive athletes, and there's studies for the average person. And I deal with this a lot with our weight loss patients because, one of the things we try to do while someone's losing weight, especially with like a GLP-1 medication, is hold on to as much muscle mass as possible. With semaglutide, for example, they as much as 45 to 50% of your weight loss can be lean body mass. So people are losing a lot of their muscle mass as they're losing fat as well.
Oh, right.
So in terms of accessibility, muscle tissue and amino acid, which is the breakdown product of protein in the body, is a slightly more accessible fuel substrate for energy production. And so, especially when you're in that semi-starvation state of like a diet with a deep caloric deficit,
Right.
And any bodybuilder will tell you, like, as they lean down for a contest, they know they stop measuring their biceps and chest and stuff because all those measurements are going down, not because they're continuing to lose fat, but they also lose quite a bit of muscle as they lean down for contest. Right. The goal is to maintain as much muscle as possible. So with the weight loss patients, we urge them to eat as much, to maintain a certain amount of protein. And that is as much as 0.75 to 1 gram per pound of body weight.
Right.
Okay. And so, for example, someone who's 250 pounds, we're shooting for around 200 grams of protein per day.
Right.
Which people think, oh yeah, I eat a lot of protein, but no, you don't probably eat 200 grams of protein a day unless you're really trying.
Diligent, right.
Yeah. So, that's like 2 shakes a day, like protein shakes.
Oh, right.
Like a chicken breast for lunch, a steak for dinner, know, and then you're adding in like some Greek yogurt in there somewhere. And it ends up being a lot of food, high protein foods, but low calorie foods. So this is, a dietitian who's trying to get somebody to lose weight, not with a GLP-1 medicine, will kind of tell you the same thing, that and someone who's never dieted before with a legitimate diet where macros are counted and stuff will tell you the first time they do it, they actually feel like they're eating more. And that's because they are adding all these high protein foods in.
Interesting.
So, yeah. But for the average person, 1 gram per pound of body weight is a lot. It's probably more than what they need. But even if you can eat half a gram of protein per pound of body weight every day, so for like 100 grams of protein for a 200-pound person, you're going to be pretty close to where you need to be. But maybe you need a little more than that. So
interesting.
Yeah. Now, maintain your muscle mass is not just a matter of protein intake. There's obviously, you need activity, and there's a lot of other factors that go into that. But just being on testosterone replacement or optimizing your testosterone level will help you maintain a higher degree of muscle mass.
That's cool.
Yeah.
Yeah, that's one thing I keep saying. Okay, I've got to work on my menu this week. I've got to do my menu this week. I've got to.
Yeah.
Okay, this is what I'm going to work out. I think those two things.
There's so much. I mean, that's if you can just like get those two like locked down as habits,
Like obey those. Like just be so diligent about that. Yeah.
And if you're trying really hard and you have to be diligent about it, then it's probably like you haven't made it those things a habit.
Right.
Yet.
Yeah.
Getting them like kind of just where they're just habitual for you.
Mm-hmm.
That's the key to success in those areas. And we tend to fall into traps of things that are easy and sort of meet the immediate need, like
Right.
like ordering pizza every Friday. It's just like kind of like what we do at our house. It's like, oh, it's Friday night.
Oh yeah.
Nobody wants to cook. Let's just order pizza.
Yeah.
Right. Which isn't necessarily a bad thing, but you gotta.
It's way easier when you make it a habit.
Yeah.
So.
Yeah. So I mean, we had talked about different modalities for testosterone replacement. Obviously, there's creams and trochets and things like that, but I generally recommend injected TRT for most men. It just tends to be the most reliable in terms of a dose response. And, it's just a matter of getting over that injection. But oftentimes, we've seen this, as you know, Cam, with other suppliers, your first, set of injections, they basically gave you like an insulin syringe like this. Okay. And so problem with these, it's self-contained needle and syringe here. The problem is that this needle is so small. It's just a fine needle. And so there's just a lot of difficulty in being able to draw that solution up into the needle. For one, from the bottle, you get a vial, so you're supposed to draw it up, and then injecting it takes just a long time and a lot of pressure, and you may not even be able to generate enough vacuum to draw up the drug and pressure to inject it. So this is like that insulin type needle, and so this would be used exclusively for a subcutaneous injection here. You can see it there. So see how fine that needle is. This is a 31 gauge needle. So generally what I recommend is something more like this. And you're going to say, oh my goodness, it's such a big needle. But this one is a 23 gauge. And what you want, if you have to give yourself an injection, you just don't want to have it in there for too long, right? So the quicker you can inject it, something like a 25 gauge or a 23 gauge needle is, I think, the better solution. In this case, this is a 3 cc syringe. So if your dose is 0.5, you draw it up to that 0.5 mark. And this could be used as a intramuscular needle, 'cause it's pretty long. Or this could be used to administer subcutaneous. For the product that I generally prescribe for my patients, which is an MCT oil mixture of testosterone, it can be safely administered subcutaneous or intramuscular. And so this type of needle and setup is ideal. It's going to work really well, both for drawing the solution up from the vial and injecting it. Okay. And I know, Cam, we've kind of switched you to a different setup, and I think you've seen it's a lot easier, a lot better.
Yeah, it is definitely easier. Like you said, the quicker that you can get the material into your body and not have to be sitting there with the needle sticking in you, the better. So
yeah, absolutely. So that's the setup.
Yeah, I remember actually in 9th grade, we got our MMR shots,
Oh, yeah.
and I fainted. I walked out of class. I was like, I don't feel well.
Oh, they did it in school?
Yeah, they did it in school, and on the way to the nurse's office, they had to catch me. And
That's such a Canadian thing to do, to inject all the kids at school.
is that a Canadian thing?
It would never fly here in the States, especially with all the anti-vaccine parents there are these days. Talking to you. Vaccinate your children.
That's funny.
There's no debate in the medical literature about vaccinating your children.
Okay, yeah, we're gonna hear about that. Thankfully, no one watches this just yet. Our fan base is still kind of low, or else we'd be hearing about it in the comments.
You can cut that if you want.
So they don't. Did you get shots when you were in school? Do you remember getting those?
I don't remember getting them in school. I don't remember getting shots in injections or in school.
Like flu shots or anything like that?
No, I don't think they give flu shots to school-age kids anyway.
No.
But it was more like those scheduled vaccines, I think. That I just remember.
Right.
Oh, I remember going to the doctor for my 6th grade shots. But I don't remember it being like a thing.
Academically endorsed.
Yeah.
Yeah.
Although that is a very Canadian thing to do.
I suppose so.
Let's just do it to them at school, and then they can't say no. I'm airdropping you that voice memo.
Yeah. Although the vaccine did injure me, I was in. No, I'm just kidding. No, I definitely wasn't.
Explains why we're all so messed up and crazy.
You know what's funny though is I when I came back to consciousness, I was laying in the nurse's office. I was laying on a bed behind kind of like a sheet. And across the way from me was one of my friends. He was also laying on a bed, and there was another person. There was like 2 other people like in the nurse's office.
All passed out.
Well, they had all been like, "I don't feel good either. Can I go?" You know. And so I think some of them were just trying to skip class.
So just watching you pass out, they're like, oh.
Or maybe some of them were kind of feeling that way. But yeah, apparently it was kind of a spectacle. But yeah, no.
Did you ever like play sick just so you could go home?
Did I? No, I was one of those people. I kind of liked school. I liked going. I played sports just like you did. So the fun part was after school. The fun part was being healthy enough to play basketball or floor hockey or whatever it was. So yeah. All right.
Okay.
All right. That's all I've got this week. Anything else you want to cover?
Nope.
Okay.
I'm good for this week.
Cool.
Got some long form videos coming up about, we're going to talk a little bit about some of the general surgery topics, hernia repair. We're going to talk about hernia mesh, and some other stuff. So stay tuned for that.
Yeah, good stuff. Okay. All right. Well, that's it for us this week. Don't forget to subscribe to our podcast if you haven't done so already. And while you're there, leave us a comment. Tell us what you're interested in. Let us know how we're doing. And if there's topics that you want us to cover, obviously, we want to hear from you. So, in the meantime, if you are curious about TRT, head over to thunderbirdmenshealth.com. That's our website. That's thunderbirdmenshealth.com. And this guy, Jordan, will get you set up. Do the testing, get you on a protocol that works for you, and can help you feel better and get that testosterone optimized for you in your life. Anyway, until next podcast.
Take care.
Take care. Bye.